So let's start with oral submucous fibrosis. Now, OSMF is a chronic progressive scarring precancerous condition. Now, as I told you earlier, the potentially malignant disorders were called as pre-malignant conditions and pre-malignant lesions. So there were three entities in pre-malignant lesions. One was your leukoplakia, the other one was erythroplakia, and the last one was palatal changes of reverse smoking. Leukoedema actually is not a part of pre-malignant lesion, but then it is considered to be a precursor for leukoplakia. So we have discussed that in that entity. All right. Now today we'll be discussing the pre-malignant conditions. Now conditions are a lot of them. It's a generalized state wherein the patient can kind of, progress into a malignant state, and he has more of potential for that. So it is not necessary that every patient who has OSMF will progress into a malignancy, which is why we have now called it as a oral potentially malignant disorder. So OSMF is also an oral potentially malignant disorder, but earlier it was called as a pre-malignant or pre-cancerous condition. Okay, so this is one definition of OSMF which every examiner is going to ask you, so you need to know it in detail. So it's, what is it? It's an insidious chronic disease. Insidious means sudden in onset. Chronic long-standing disease affecting any part of the oral cavity or the pharynx. That means it affects the mucosa, oral mucosa, pharyngeal mucosa, all right, oral cavity and the pharynx. Occasionally preceded by and or associated with. That means sometimes it, along with, the disease, you have juxtaepithelial inflammatory reaction, or first the juxtaepithelial inflammatory reaction will come in, followed by the disease, all right? So what is juxtaepithelial inflammatory reaction? It means that there is inflammatory reaction just below the epithelium, that is adjacent to the epithelium. The word adjacent, juxta means adjacent. Epithelium, the structure adjacent to epithelium is your connective tissue. So just below the basement membrane of the epithelium, you'll actually find inflammatory reaction, which is followed by fibroelastic change in the lamina propria. So when I say fibroelastic change, collagen fibers are there and elastic fibers are there. So you will see a lot of these fibrous changes in the lamina propria, all right? Otherwise, your lamina propria is your superficial connective tissue just below the basement membrane. So what all are the changes that you see in the superficial connective tissue? One, you find juxtaepithelial inflammatory reaction. That is, a lot of inflammatory cells will be there. Two, you will find fibroelastic change in the lamina propria. Then what happens is there is a lot of epithelial atrophy. Now, till now we were talking about the changes in the lamina propria or in the connective tissue. Now the definition says not only that there are majorly changes in the connective tissue, we also find epithelial atrophy. Atrophy means reduction in thickness of the epithelium is called as atrophy. So you find epithelial atrophy leading to stiffness of the oral mucosa. Now, stiffness means there is a certain feel when you actually pinch your cheek, for example. So that's your buccal mucosa, right? So there's a certain feel for, when you pinch your cheek. But in case of oral submucous patients, it will become very stiff. That's because it will lose its elasticity and there'll be a lot of fibers, extra amount of collagen fibers would be there. So there is stiffness of the oral mucosa as a result of all these things, causing trismus and inability to eat. Now, I hope all of you all are familiar with the word trismus. Trismus is inability to open the mouth is called as trismus. And because obviously, if the patient cannot open their mouth, there will be difficulty to eat. So every part of this definition is very important, which is why I've just put the definition in one slide. So again, coming to repeat it, it's an insidious, suddenly occurring, but long-standing disease, chronic disease, affecting any part of the oral cavity or the pharynx, that is any mucosal tissue, occasionally preceded by or associated with juxtaepithelial inflammatory reaction. There is inflammatory reaction in the lamina propria just below the epithelium, followed by a fibroelastic change. That means there is increased fibrosis in the connective tissue. With epithelial atrophy, the overlying epithelium undergoes an atrophic change, leading to stiffness of the oral mucosa, causing trismus and inability to eat. So the last three things are clinical features. If you are a clinician, That is what you will find. You will find that the patient has got stiffness of the oral mucosa, there is trismus, and there is inability to eat. That will be the patient's complaint, and you will find it as a clinician. And the stuff which is there in the middle of this definition is all histopathological, but that you will see it in a biopsy of the patient. So oral submucous fibrosis patients are very common in this part of the world. It is very common in the Indian subcontinent, that is India, Pakistan, Bangladesh, Nepal, Sri Lanka. All right, so this is the disease of the Indian subcontinent. They have been reported in many Western countries as well, a little here and there sporadically, but basically it is a disease of the Indian subcontinent. So when you come to clinics, you'll find a lot of patients with these oral submucous fibrosis. Of course, they wouldn't know that that's the problem, but it's very common. Now, OSMF has a malignant transformation rate to squamous cell carcinoma of about 7 to 30%. All right. So which means that if there are 100 patients, any number from 7 to 30 of them can undergo a malignancy. 30 people getting a malignancy from an OSMF is a huge number. So it has to be taken very seriously. And first of all, the patient might come to you with some other problem. His primary complaint might not be OSMF, because he wouldn't have much of a complaint, because it's a very long-standing disease. So over a period of time, the patient would have adjusted himself with the inability to open his mouth and things like that. He wouldn't realize it until and unless there's a pain or an ulceration somewhere on the mucosa. Or initial phases, he would have complaint of burning sensation, which over a period of time would have reduced or sometimes increased. If the burning sensation has increased, it is again a reason why he can come to the dentist. Otherwise, just because there's inability in opening the mouth, most of them wouldn't come, because it is a very gradual symptom. So one important point about OSMF is, one was the definition, and two, it's the etiopathogenesis. Now, etiopathogenesis by itself can be an essay question. So the multifactorial etiology can be actually divided, to make it more easier, into local factors and systemic factors. So the local factors are chilies, areca nut, betel quid consumption, or spices. Now, chilies and spices, we as Indians, we consume a lot of these spicy food. So different type of spices are available, chilies are available. So there are parts in our country where people are, they really have very spicy, extremely spicy food. All right. So spicy food, and you must have seen a lot of these rickshaw pullers, or the poorer sections of the society, when they don't have anything to eat, they would just eat a chili, yeah, or maybe they would eat a roti with a chili. So all these are reasons why it will increase the case of OSMF. Now, chilies alone cannot cause OSMF, but it has to be multifactorial etiology. So there'll be tobacco associated with it. So tobacco in some form. All right. So areca nut and betel quid, these are basically pan chewing people who place tobacco also along with slaked lime inside the quid. So all these things have a certain effect on the oral mucosa and can lead to OSMF. Now, spices, again, different type of, we all have spicy food. Indian food has a lot of masala, right? So that again can be a reason why we have more of this, prevalence of OSMF. Now, systemic factors are the general factors which can lead to this disease. One is nutritional deficiency. So one, we are taking all these masalas, and secondly, along with that, we don't have proper nutrition. That is vitamin B. Even if you take nutritional food, after a certain age, the food that you take don't get completely absorbed. Like, you can have a lot of vitamin B and iron and things like that, but it doesn't really get absorbed. Sometimes with age, sometimes with other factors. So which is why we always take vitamin supplements. Like now it's a COVID time going on. We are allowed to take zinc supplements or vitamin B complex or vitamin C supplements. That's because we don't take enough, and even if we take enough, sometimes the body does not absorb. All right. So nutritional deficiency is a very common factor associated with it. The genetic predisposition. This can also be possible. If it runs in the family, that means you have a gene associated with it, then you can't help it. You will develop it. All right. Autoimmunity is where your own body develops antibodies against, one's own body. So this can also be a reason. So we'll, just to make it more easier for you all to understand this lesion, just look at this picture. You can see that the mouth opening of the patient is reduced. Like if you try to open your mouth, you definitely would be able to open it in a vertical manner and much more than this. Secondly, you can actually see that look at the buccal mucosa. Can you see a blanched area? You can't really, it is a white lesion somewhere towards the anterior sides of the buccal mucosa, but by and large, the dorsal surface of the tongue, the posterior soft palate, the hard palate, as well as the retromolar area and the buccal mucosa, they are all blanched in appearance. Blanched with a palely white in appearance, right? So, do you think that the white color is due to keratinization? Partly, yes. Otherwise, why do you think this blanched appearance is there? If it is keratinized, it would be a very opaque white appearance. This is not an opaque white appearance. It's a blanched, pale appearance, all right? So it's something like, you can't, there's no blood, the patient doesn't have any blood. So maybe that is why it's looking pale. So this appearance is because you have blood vessels inside the, your connective tissue, but it is not really visible. That's because there's a lot of fibrotic changes inside the connective tissue. So what happens is when there is excessive fibrosis in the connective tissue, they will mask the blood vessels coming out of this. All right. So the blood vessels appearance of the blood vessels will be masked, and it will not allow the erythrocytes to be seen through from the fibrosed connective tissue. Epithelium is atrophied, but you really can't find out the continuity of you can't really find out the continuity of the blood vessels because of the excess fibrosis. So which is why we can see this pale area or a blanched mucosa. All right. So you can see another patient out here. There is blanching not only in the palate and the soft palate and the hard palate over here and the uvula, and just see the mouth opening. The patient has stretched to try open his mouth. There's a horizontal opening of the mouth. He's not able to open it properly. See the picture below, the inner part of the lip. He must be keeping a beetle quid in the lingual mucosa, in the labial vestibule over here. So this also can be a reason why there is a blanching in this area alone. So pan chewing or beetle quid chewing is a very habitual thing. My patient would have had this habit for 20, 30 years together. All right. So when it's a very habitual thing and every day he's going to do the same thing, what happens is you develop these kind of changes on the oral mucosa. Initially, it will be burning, and then it will be epithelial atrophy, and there'll be a lot of, gradually, there'll be a lot of fibrosis in the connective tissue. So that's what you can see here. So this is a typical picture of a patient. So why I showed you this picture is, these pictures should be clear, because these are the kind of patients who will come to you with a different problem. They would have problems in their, pain in their oral cavity or pain in the mouth or whatever. That will be their basic complaint. But then when you see, they would already have one, high grade oral submucous fibrosis. So they're basically having the potential to develop an oral cancer. When the case of an oral cancer comes in, the fact that he has a pain in the tooth because of a carious teeth is not very important. The primary factor to be taken care of is, of course, the pain by small restorations, but then you have to ensure that the patient is well aware that he can go into an oral cancer. So coming to the etiology one by one, I've already told you, chilies, irritating spices, vitamin D deficiency, and beetle quid chewing. That is one. Now, what all are there, the contents of the beetle quid? The beetle quid consists of aracanut and slaked lime. You know that. Chuna lagate hain uske upar, right? So that slaked lime is not very nice. It increases the, risk of the disease. So along with tobacco, and aracanut, they also use slaked lime and sweeteners. So these are all wrapped in beetle leaf, and that is how they chew it. Okay. So the slaked lime acts on the aracanut to release an alkaloid called as aracadine. So basically, slaked lime will increase the risk exponentially. So if you don't use slaked lime, maybe not as much as alkaloid would be released as much as the one upon which uses a slaked lime. So it produces a feeling of euphoria, a good feeling. Euphoria is a feeling of happiness. Why do people smoke or chew pan? Just to feel light and feel happy. So that feeling of euphoria comes in. It's a psychosomatic thing, when you have these kind of substances. So this will cause epithelial alterations. That means you have to understand there are 2-3 things which we have discussed here. One, Chili is okay, that's a part of food. If you're talking about that betel quid chewing, that betel quid itself is a very complicated structure. If you look at it, there are so many things that the fellow is going to add into that. The basic stuff is arecanut along with tobacco and slaked lime. So all the three will have different effects. So I told you that slaked lime along with arecanut can lead to the production of an alkaloid called as arachidine. Now, tobacco by itself, this arachidine will have an effect on the connective tissue. Please understand, the arecanut will actually leach out a alkaloid called as arachidine, and this arachidine will have a deleterious effect on the connective tissue, that is your collagen fibers. It will increase collagen fiber production. Okay. Now, coming on to tobacco. Tobacco will have no effect on the, not much effect on the underlying connective tissue or collagen, but that will have major effect on the overlying epithelium. The epithelium will be atrophic. It will cause atrophy of the epithelium. All right. So epithelial alterations can be caused by tobacco. The nutritional deficiency will increase the severity of the fibrosis. So you can see how these factors are all playing together. That is, first of all, the patient is having food with a lot of chilies and spices. Secondly, he has nutritional deficiency, that whatever food he's taking, perhaps the nutrition is not going in, being absorbed properly. Thirdly, he's chewing pan. So in the pan, again, he has three different things. The arecanut along with slaked lime is causing the problem of an release of an alkaloid, which has an effect on the collagen fibers in the connective tissue. And separately, the tobacco which he uses in the betel quid is affecting the epithelium. So it is not only making the epithelium atrophic, but it is also increasing the collagen fiber, production in the connective tissue. So these are things which you have to understand. Now let's take it up one by one. What does the chili do? Now what chili does is, there is something called as a capsaicin. All right. So capsaicin is a component of the chili. So that is a mild irritant. So this capsaicin in the chili will cause elastic degeneration of collagen. All right. It will cause elastic degeneration of collagen. Collagen fibers will get degenerated. So this has a mutagenic effect. What do you mean by mutation? Mutation is a change which happens before you develop cancer. All right. So it is a kind of a carcinogenic change called as mutation. This mutation will increase the tumorigenicity of tobacco. That means the oncogenicity, the ability of tobacco to produce a cancer is increased because of mutation. And how does the mutation take place? Because the capsaicin in the chili will degrade collagen. So increase in risk of cancer in the upper digestive tract is a dose-dependent manner. Now, what do you mean by dose-dependent manner? Remember, I told you that mostly this is a long-standing habit. The person must have started chewing pan at 10, 12 years of age. And then now he's, 40, 50 years of age. So over a period of time, over a period of 10 to 15 to 20 years, he has had this habit continuously, which is why there's an increase in risk of cancer. Okay. So what does the arecanut do? The main etiological factor I told you is the arecanut. So arecanut, what it does is, it contains products like, arecanut containing products are available in the market quite a bit. Gudka, pan masala, etc. So they contain alkaloids like arecolin, I've already told you, arecolin, arachidine, guaifenesin, guacolin. All right. All these are present. Plus there are some substances called as flavonoids, tannins and catechins. Now all these things will have two effects on the collagen. One, it will degrade the collagen. It will reduce the degradation of collagen. Two, it will increase the proliferation of collagen. All right. So collagen may be turnover hota hai, in the sense the old collagen will be lost and new collagen will replace it. That is normally how our body works. But in this case, what happens is new collagen is formed. There's a lot of collagen proliferation because it is increasing the proliferation rate of collagen. But at the same time, there is reduction in degradation as well. That means the collagen is not breaking down. It is not, the older collagen was also there and more newer collagen is getting added to it. So as a result of which, what happens? The amount of collagen increases in the oral cavity or in the connective tissue of the buccal mucosa or whichever oral mucosa. So as a result of which the fibrosis increases, then you will not have that elasticity in the cheek. Then it suddenly becomes very firm in nature. Now coming on to each of the way in which betel quid is going to act. Now chronic placement, remember, dose dependent manner, matlab, how much ever time, the time and frequency of the habit, matlab, if the person has got the habit of keeping a betel quid 24/7 inside his mouth, that means he increases the risk very many times than a patient who uses a quid once a day. All right, so chronic placement of betel quid or the aracanet will lead to release of aracolin. This aracolin is an alkaloid. This alkaloid will causes fibrosis of the mucosa, as a result of which there is rigidity and trismus. Okay. Next is I've already explained this, the role of aracolin. Aracolin along with slaked lime undergoes hydrolysis and produces arachidin. Arachidin is again a alkaloid. This will increase the fibroblastic stimulation and causes increases in collagen synthesis. So increase in number of collagen fibers. Now, I also spoke about tannins and catechins. So what does a tannin do? It inhibits collagenases. Now, what are collagenases? Whenever you hear the word aces, we know that it is a enzyme. So an enzyme which breaks down collagen is called as a collagenase. Please understand. An enzyme which degrades collagen on a normal day is called as a collagenase. Now, what happens to this collagenase? These collagenases are inhibited. The tannins will not let the collagenases act. So, as a result of which, the action of the collagen goes down. So, if the action of the collagen goes down, it is very clear that the collagen will not be degraded. So, on one hand, you have increase in number of collagen, and on the other hand, you have reduction in degradation of collagen. So, what happens? The net amount of collagen which you have in the oral cavity is going to be increased. All right. So this is what happens in Osmf. So the next, but now all these points which I'm showing you is basically pathogenesis, mechanisms of pathogenesis of Osmf. All right. So this itself can be a long essay because it's a PG level question. So aracolin again can increase the generation of reactive oxygen species. So reactive oxygen species are increased in cases of cancer-like conditions. So this ROS will increase the oxidative stress on the cell. So as a result of which it increases it activates the transcription factors. What are transcription factors? For that you need to know what is transcription. The whole idea of making new DNA, genetic material, is transcription. All right. So it stimulates the fibroblast and increases the collagen production. Fine. So that is how we have more of fibrosis in Osmf. Now the next action which an aracolin does is, I told you there we spoke about collagenases. Now these TIMPs are also type of collagenases. All right. So just understand the mechanism. Increased amount of TIMPs, tissue inhibitors of metallic proteinases. So these metalloproteinases are like collagenases. These are the enzymes which can actually cause degradation of collagen. Okay. So matrix metalloproteinases, that is the full name of the enzyme is matrix metalloproteinases. They're also called as MMPs. So these MMPs actually have the ability to inhibit, it has the ability to degrade collagen. All right. But then there are some factors called as tissue inhibitors of these matrix proteinases. That means there are some factors which will inhibit the normal action of these collagenase or these matrix metalloproteinases. That means it will not let the collagen degrade. All right. So these are actually inhibitors of matrix metalloproteinases are also called as TIMPs, tissue inhibitors of matrix metalloproteinases. So I told you in the previous slide that the activity of the collagenases are brought down by the tannins. So this is a similar action, but a different activity. That is, aracolin is doing it here. What does it do? Aracolin will not directly act on the matrix metalloproteinase or the collagenase. Instead, it will increase the tissue inhibition factors, which will act in turn on these MMPs. All right. So there are tissue inhibitors of matrix metalloproteinases which basically will increase the production of collagen and reduce the degradation of collagen. So all these things have the same effect ultimately, all right, which is why you have an increased amount of collagen fibers. Now, what's the next alteration? The erecolin can alter P53 and checkpoint kinase. Now, understand that P53 is a tissue tumor suppressor gene, all right. So there is something called these genes are very important in all the metabolic activities in our body. Now, checkpoint kinases, they act on the mitotic cycle. Now, G2 and M phases, gap2 and mitotic phase. If you go back to your mitosis had your cell cycle. Cell cycle has got 3-4 phases: gap1 phase, mitotic phase, gap2 phase, synthetic phase, and then mitosis in turn has many other phases, PMAT, that is prophase, metaphase, anaphase, and telophase. Now, just what I'm trying to say is that all these phases are controlled by genes, all right? So this erecolin will arrest the G2 phase and the M phase. That means mitosis will not happen, and the gap2 phase, the cell is gotten stuck in the gap2 phase. So this will suppress the endothelial cell population. That is, endothelial cells are those cells which are surrounding the blood vessels. So the blood, obviously the endothelial cell population is suppressed. That means the blood vessel will not be proper. So if the blood vessel is not of good quality, what happens? There is hypoxia. What is hypoxia? Reduction in oxygen. Blood is the one which carries oxygen to the tissues. So when blood vessel itself is affected, what will happen? There will be less of oxygen to the tissues, as a result of which there will be atrophy of epithelium and causes carcinogenesis. So erecolin and the keratinocytes. What are keratinocytes? Keratinocytes, I have discussed in your first year, that these are specialized cells which are seen in both non-keratinized epithelium as well as in keratinized epithelium. And they are called keratinocytes because they have tonofilaments, and basically they differentiate from the basal cells to the stratum corneum, all right? They move from the basal cells to the stratum corneum, which is why they're called as keratinocytes. So these keratinocytes will actually cause differentiation of fibroblasts into myofibroblasts. Now you have to, this concept is very important to understand. One is a fibroblast that you've already learned about. Fibroblasts are those cells which produces collagen fibers. What are myofibroblasts? Myofibroblasts are those which are actually some different type of fibroblasts which are seen in cancer-like conditions, all right? Tumors, basically in tumors, you find these myofibroblasts. So from the word itself, you should understand that myofibroblasts are fibroblasts which have muscle-like properties. What is the property of a muscle? Muscle can contract. So muscle has got smooth muscle, actin, and myosin. So this actin and myosin will be also present in these special fibroblasts. Usually a fibroblast can produce collagen fiber but cannot contract. Contraction is a basic concept which your muscle exhibits. So this is a special type of fibroblast which shows muscle-like properties. That is called as a myofibroblast. All right. So the extracellular matrix will contract and cause fibrosis. So why will it contract? It will contract because the fibroblast has the ability to contract, which is why it is called as a myofibroblast. So this will lead to fibrosis. It is something like a wound healing. In your normal wound healing also, when there is a large wound, have you seen that the large wounded area would become shrunken in a while? That shrinking also takes place due to shrinking of these fibroblasts, and it causes fibrosis. All right. So coming to the next slide. Now, there is copper content in the arecanut. Now, they can ask you all these things for Viva. All right. There is copper content in the arecanut. We were talking about erecolin and erecadin contents of the arecanut earlier. Now, we are talking about the copper content of the arecanut. Now, copper contains lysyl oxidase. This is again another enzyme. All right. So, lysyl oxidase can stimulate the fibroblast proliferation and increase the collagen synthesis and cross-linking. Again, another reason why you have more of collagen in the lamina propria. So external stimuli can also be there. That is increased fibrogenic cytokines, basic fibroblastic growth factor, tumor growth factor, beta, platelet-derived growth factor, etc. So you just need to know the names of it. I'm just saying that all these growth factors are also increased so that the increase in amount of, collagen is there in the connective tissue. It happens due to various factors. So just to keep it in a nutshell, we discussed about factors in your arecanut, that is your alkaloids. When it is hydrolyzed when used with slaked lime. It gives rise to alkaloids. Then you have tannins, which are flavonoids. Then you have copper in the arecanut, which has lysyl oxidates. And then you have tissue inhibitors of matrix metalloproteinases. All these things will have two actions. The first action is increase the collagen deposition. And the second action is reduce the collagen degradation. So whatever be the action, the effect is the same. Even if the number of collagen fibers increases or the degradation of the collagen fibers decreases, the amount of collagen will increase due to both the reasons, which is why you have these changes in the lamina propria. Plus, we also learnt about the factor that epithelium becomes atrophic. Connective tissue is becoming hyperplastic with a lot of fibroblasts, but epithelium is becoming atrophic. Why is the epithelium becoming atrophic? Because the blood vessels are becoming hypoxic, as a result of which the epithelium is not getting much of nutrition and oxygen, and slowly it will become atrophic. So these are these changes, the changes of accumulation and in the extracellular matrix will happen in different stages. All right. So we'll discuss these stages one by one. Yeah. So we'll continue with clinical features today. Now, clinical features of oral submucous fibrosis can be divided into two phases. That is your early OSMF and advanced OSMF. Now, early OSMF, we'll take up the early OSMF first. The patient will have a kind of burning sensation. Now, a patient, that will be irritable to the patient because he would not be comfortable having a burning sensation when he has some hot or spicy foods. So initially he'll try all his techniques which he can to reduce the burning. But ultimately when it doesn't go away, that is when he'll come to the dentist. So when you examine the patient's oral cavity in this state, you can actually see blisters and vesicle formation. Now you need to know what is a blister and what is a vesicle. A blister or a vesicle is basically a small elevated lesion which is filled with some kind of fluid. So such a elevated vesicle, when it is filled with pus, it is called as a pustule. All right. So here we don't have pustule because it is not an infective process. You will rather find fluid-filled vesicles like that's called your blisters or vesicles. All right. So the first stage would be, some patients will come with a burning sensation. Some of them will come with complaints of blisters or vesicles. Now, the more peculiar or characteristic feature of OSMF in the oral cavity is that in the oral cavity, whatever blisters or vesicles that form can lead to ulcerations because you keep eating food. So there's a lot of constant trauma which happens from friction, either due to eating food or chewing or speaking. All this can cause a certain amount of trauma, as a result of which these blisters and vesicles are very thin walled, so they can ulcerate. So when it ulcerates, obviously it's going to pain. That is when the patient will actually come to you. So the patient can come to you with either of these complaints, that is burning sensation in the oral mucosa, blisters and vesicle formation, as well as ulcerations. Now, some of them will complain about excess salivation and some of them will complain about dry mouth. That means both can be features of OSMF. All right. So there is a defective gustatory sensation as well. The taste sensation is not proper. Then there's recurrent stomatitis, inflammation in the oral cavity. So again, inflammation in the oral cavity can cause redness as well as burning sensation. So that's about the early OSMF. As far as advanced OSMF is concerned, you will find that the patient has blanched opaque mucosa which has a marble-like pallor. Now usually marble is white in color and the oral cavity is actually pink in color. So when the pink color of the natural oral pink color of the oral cavity goes away and you find a blanched pale white appearance, it will be an opaque appearance. All right. When it is a blanched translucent white appearance, it can be a leukoedema. But when it is very blanched and opaque and you have that hard, firm feeling when you kind of touch it, that can be an advanced stage of OSMF. So there is stiffening of the rigidity of the mucosa. I told you that the muscles, you have buccinator muscle in your buccal mucosa. So the muscle will start degenerating because it will be replaced by collagen fibers now, all right, or elastic fibers. So as a result of which, there will be a lot of firmness in the buccal mucosa. So you will start to find that in a period of time, there'll be vertical white fibrous bands in the oral mucosa. So how will you examine it? You have to keep your, like if you have to examine the vertical bands in the buccal mucosa, you have to, it is a kind of a, you have to use two fingers to examine it. You will keep the thumb, your thumb in the inside the patient's oral cavity, and the other four fingers outside on the cheek. Matlab, inner surface of the buccal mucosa you will have your thumb, and outer surface of the cheek you will have the other four fingers, and then or the other one, the index finger. And you can actually move your hands above and below the cheek of the patient. That is when you'll get to know whether there are presence of any vertical bands. All right. So these fibrous bands can also be appreciated around the lips. That is your orbicularis oris muscle. All right. This muscle also can be degenerated. All right. So that is very important to know, that if there are presence of vertical bands, this again has a lot to do with the type of um, the type of habit the patient has. Coming on to say that some patients you must have seen has the have the habit of chewing pan and spitting it wherever they figure out. So they keep spitting it all over the place. So if the habit is of spitting out, what happens when you spit out? You have to actually purse your lips, and then you have to force the orbicularis oculi, oris muscles of the lips to push out the saliva as a spit. So habitually, when the patient keeps on spitting out the saliva through the orbicularis oris muscle, what happens is there is a lot of fibrous glands which occur in the orbicularis oris, which is why in a patient where you find, patient will not give you a correct history whatsoever, but when you see fibrous bands around the lip of the patient, you can obviously ask the patient, do you actually spit out the pan? He'll say, yes, I have the habit of spitting it out. But at the same time, if another patient comes to you with fibrous bands in the posterior soft palate or the pharynx, that is more of stiffening of the soft palate or the pharynx, you can rest be assured that this kind of patients would actually swallow the saliva. Okay, the pan and the saliva, that mixed saliva, they will swallow it. Some people swallow it. When they swallow it, it hits the pharynx or the posterior part of the soft palate more often, as a result of which you will be able to find these fibrous bands in the posterior part of the soft palate. But in case of spit, the habit of the patient is spitting it out, you will find them near the orbicularis oris muscle. So a lot will depend upon your history taking techniques as well, because the patient will not be able to tell you exactly, because he is a layman. So it is up to you to take the history out of the patient. So in such cases, you will find where the patient swallows the spit, saliva, you will actually find that the patient has got a fixed, deviated, or a shortened uvula. Now, when I say fixed uvula, you can move your uvula. That is why you certain consonants or certain alphabets, when you speak in different languages, it's very important for you to roll your tongue or move your uvula. All that is possible only if it is in the normal condition. But if it is affected by the fibrous bands of the OSMF, there are chances that the patient will not be able to swallow properly, neither speak properly, because there's a fixed, deviated, and a shortened uvula. Now, the next change that can occur in an advanced stage is impairment of the tongue movement. Again, coming to the tongue is basically a muscular organ. It is also a sensory organ, but it is a motor organ as well. So the motor activity means that it has a lot of muscles, and these muscles, intrinsic muscles of the tongue, they're the ones which help us speak a lot of consonants and vowels. So if your tongue doesn't move properly, because if the muscles of the tongue are degenerated and becomes fibrous, don't you think so the tongue will become firm? So when it becomes firm, you will be unable to move it. In extremely advanced cases of OSMF, the tongue movements almost become nil. All right. So that is when the patient will come to you with a lot of problems. But all these will be very gradual. Advanced stage will be very gradual. So many a times the patient would have already learn to live with it. All right. The next inability would be, you should tell the patient to blow or whistle. He will not be able to whistle. Now to whistle, you need to use the buccinator muscles of your cheek and the muscles of your tongue, and even the orbicularis oris muscle of your lips. So whistling is a complicated process where all these facial muscles have to be used. So if all these muscles are going to be affected by OSMF, the patient will be unable to blow or whistle. So difficulty in mouth opening, I've already told you. Now, how will you assess the mouth opening extent? That is interincisal distance of less than 20 millimeters. So the incisal tip of the incisal edge of the upper central incisor and incisal edge of the lower central incisor, when the patient has opened his mouth completely, should be less than 20 millimeters. That is when we say that the patient has difficulty in opening his mouth. So then he'll also have a nasal twang in voice, because again, the speech will be impaired because all these muscles are degenerated. Then he'll have dysphagia, because the pharyngeal muscles will also be degenerated and become firm, as a result of which he'll have dysphagia. Then he'll also show petechiae and melanosis. Petechiae are pinpoint hemorrhages seen on the soft palate, and melanosis is some extra pigmentation which you will find on the uh, palate. I've already discussed why you have extra melanosis in a smoker. Uh, the same reason is why you see melanosis in a OSMF patient as well, because melanosis is related to use of tobacco, and smoking obviously is combustion of tobacco, and OSMF is basically a non-combustive mechanism of using tobacco, that is pan chewing, again where tobacco is chewed. It's not smoked, it is chewed, all right, but the effect of the tobacco is the same, as a result of which you will have melanosis in these kind of patients. Now clinically, the clinicians have tried to stage the OSMF. Now going back to what is grading and staging. Now if you remember, grading is the histological grading, like a pathologist will decide what extent the dysplasia is present, or if it is present or not present. The features which you see on the slide is called as grade. So that will be the point of pathological reference. And staging is what the clinician sees inside the clinic. All right. So it is always clinical staging and histopathological grading. So for OSMF, the stage 1 shows only fascial bands, that is fibrous bands in the fascial pillars on the pharynx. And stage 2 will show bands, fibrous bands, not only in the fascial pillars, but also in the buccal mucosa. And in the third stage, you will have these fascial pillars, buccal mucosa, and the lips showing these kind of fibrous bands. So that's about the clinical staging of OSMF. Now, functional staging can also be given depending upon what is the mouth opening of the patient. So if the mouth opening of the patient is less than, more than 20 millimeters, between 11 to 19 millimeters, or less than 10 millimeters. Now, always, as I've already told you, gutka, when chewed and spat out, if the patient spits it out, may develop grade 1 OSMF, that is around the lips, and the patient who chews and swallows it will develop grade 2 OSMF near the pharynx. All right. So please understand, clinician will take a proper thorough history of the patient, and then see the fascial bands and decide the bands seen on the fascial pillar, buccal mucosa, as well as the labial lip, and decide which clinical stage it is. And functionally, the clinician will decide the mouth opening, the extent of the mouth opening, and decide what it is, right? So if the patient has got a habit of spitting out, the chewed pan, obviously at least he's throwing out the tobacco. So the extent of the lesion will be considerably lesser, maybe only grade 1. Remember, grade is a histopathological entity, not a staged entity. All right. So fascial bands will be seen when you swallow, but I'm saying stage 1 will be, grade 1 will be seen when the patient will chew and spit it out. Histologically, it will be a better situation. All right. But at the same time, when the patient tends to swallow it, histologically, it is not going to be a great situation. All right. Because the patient is ingesting the toxin. Okay. He's not spitting it out. He's ingesting the toxin. Now, if you ask me, is staging important or grading important? Both are important, but grading is definitely more important than staging. I mean to say that the histopathological basis is definitely more important than clinical staging, because there are some stages where some diseases where most of them you will not see the clinical features until and unless on a tissue level the changes have taken place to a very large extent. What I mean to say is, already there would have been a lot of tissue changes or a cellular changes on a cellular level that must have taken place. Initially, when the cellular changes takes place, the patient will not have any clinical problem. The clinical symptom will come only after much damage has happened in the cellular level. So it is very important for us to see in the pathological basis that how much cellular problem damage has taken place, and then correlate it with the clinical appearance. All right. So which is why a stage 1 clinically, maybe the patient only has stage 1, need not necessarily be grade 1. It can be grade 2 also. Okay. So it is very important to know that the cellular features are extremely important in predicting how the lesion will progress or how the lesion will respond to a treatment process. So the histopathological grading is extremely important. All right. So coming on to the next slide, histopathology. Now I say that it's a white lesion. That's why it is also called as a OPMD, that is your oral potentially malignant disorders. So it will show pathological keratosis. So epithelial hyperkeratosis is seen in early lesions. After that, epithelial dysplasia may be present. The dysplastic features are the same features which I discussed in leukoplakia. So that is very extremely important. Then you have atrophic epithelium and complete loss of retapex in the older lesions. All right. So epithelium will become thinner with a loss of retapex in the older lesions. All right. So that was the epithelial changes. Always understand, when we talk about these lesions, we would rather talk about the epithelial changes as well as the connective tissue changes. All right. So initially I spoke about epithelial changes. That is, the thickness of the epithelium will become reduced, atrophic epithelium in some cases. Before that, it might show some amount of dysplasia. And the first point was it showed epithelial hyperparakeratosis. Epithelium, we discussed 3 of these features. Now coming to what all changes are seen in the connective tissue. Now, as I told you, this is a lesion where the changes are seen in the connective tissue, but malignancy will arise in the epithelium. It's an irony. All right. The changes are seen in the connective tissue, but predominant changes are seen in the connective tissue, but the malignancy will occur in the epithelium. All right. So based on the following criteria, we have connective tissue changes which are discussed. Presence or absence of edema. Edema is intracellular accumulation of fluid is called as edema. So presence or absence of edema. Natural nature of collagen bundles. All right. So in the initial stages, you will find collagen fiber proliferation. So they'll not have formed bundles. But in later stages, these fibers would have formed thick bundles. And the bundles in later on stages, these bundles would have joined with each other, intermingled with each other, and formed larger bundles. All right. So that is a grade of the disease. So it is based on these grades that we are going to discuss the histopathology of the connective tissue. Overall fibroblastic response. Always remember, the cellular fibroblast is a cell, right? So cells will be present in the initial stage of the lesion. All right. So there'll be a lot of fibroblasts which are ready to produce collagen fibers. So as and when all these fibroblasts will produce collagen fibers, they would all mature into a fibrocyte. So when they mature into fibrocytes, now they have produced a lot of collagen fibers which have now become bundles. All right. So there's overall fibroblastic response. Then the state of blood vessels. Now blood vessels, if you suppose have a normal amount of X amount of blood vessels in the normal mucosa, the number of blood vessels is going to go down considerably in case of later lesions, because these blood vessels will be collapsed in between the collagen fiber bundles. The collagen fiber bundles will keep on proliferating as the grade increases. And this collagen fiber bundle proliferation is going to basically collapse and mask the appearance of these blood vessels. Plus, as I already said, that there'll be a lot of hypoxia because of that. And you will actually see very less number of blood vessels, which is why again you see a very opaque, white, avascular looking lesion. All right. Though it is not avascular, but that's how it looks, pale and opaque white. Then you have cell types in the inflammatory exudates. Now, inflammatory cells are different. We have neutrophils, we have lymphocytes, monocytes, we have plasma cells. So the inflammatory exudate is going to be different with the stages. Now let's see how we can discuss it. Very early stage, you have fine fibrillar collagen or a marked edema, plump fibroblasts. Remember I told you fibroblast cells will be more. Dilated or congested blood vessels, मतलब इसमें blood vessels हमको दिखता है. More of neutrophils than eosinophils, because earlier lesions you will find more of neutrophils because it's a very chronic lesion. Later on, in the later stages, you will start finding lymphocytes. All right. So see the next stage. In early stage, you will find juxtaepithelial hyalinization. Just below the epithelium, you will find hyalinization. It's not hyaline cartilage formation. Hyalinization here means that the fine fibrillar collagen, which was seen in the very early stage, has now become more bundled. So the bundled appearance has started to forming densely. They kind of densely pack with each other. So this dense packing of the collagen has formed a hyalinized area that's called as a juxtaepithelial hyalinization. In the next stage, ideally, the edema would be a little increased, but then you will not be able to see the edema because it will totally be masked by these collagen bundles. So there is separate thick bundles of collagen. Now the plump young fibroblasts will be slightly reduced. I told you the cell number will start reducing and the fiber number will start increasing. All right. So dilated congested blood vessels are the same in the early stage. Later on, when the fibers become very increased in number, the blood vessels will become reduced. Then lymphocytes are more than the eosinophils and the plasma cells. So now you can see that from this stage onwards, lymphocytes are increasing. In moderately advanced stage, you have moderately hyalinized collagen, thicker collagen bundles, very little edema, spindle-shaped nuclei in adult fibroblasts. Fibroblasts are also become very spindle-shaped in nature. That means they're becoming more atypical. Constricted blood vessels. I told you the blood vessels will be collapsed later on when the number of collagen fiber bundles will increase. And lymphocytes. So in the next stage is your advanced stage. You find complete hyalinization of the bundles. Now I'll make more sense to it. Initial stage, you will only find thin fibrils, single collagen fibrils. In the later stages, all these fibrils together will form fibers. Many of them will together intermingle and form fibers. In the last stage, what happens is all these fibers together will form small bundles. And in the next stage, several small bundles together will form larger bundles. And these larger bundles will actually be very closely situated with each other, and it will look as if it is a hyalinized structure. So that is what happens in the advanced stage. And edema will be absent because progressively, when it starts from very early to advanced stage, the edema will progressively start decreasing. All right, it will become absent. Hypocellular connective tissue, I told you cellular number will decrease. So the number of fibroblasts will now become lesser. The blood vessels become narrow and completely obliterated. What do you mean by that? The blood vessels, I told you, are present, but they will get collapsed in between these proliferating fiber bundles. And lymphocytes, number of lymphocytic proliferation will increase. Melanin containing cells are also seen now. So where you find melanin containing cells? In the epithelium. All right. So the normal place where you find melanin containing cells is the basal cell layer of the epithelium. These melanin containing cells are now surrounded by dense collagen. So which means there will be loss of pigmentation as well. All right. So which is why again you find a very opaque marble-like appearance which is white in color of the oral mucosa. So that's about the advanced stage. Now histologically you can actually grade the lesions. Remember I told you you have clinical staging and histological grading. So according to the histological grading, you have grade 1, grade 2 and grade 3. Even what I discussed before, very early stage, moderately advanced stage and very advanced stage, these are also histological grades. So this is a different histological grading where we have spoken as grade 1, grade 2, grade 3. Same features which I discussed in the last couple of slides is what is kept here. You can see that edema is increased in grade 1, and by the time it comes down to grade 3, there is no edema. Cellularity is also absent. Only thicker bundles of collagen will be there. Okay. So that's about grading. So this is a patient's picture which shows hockey stick uvula. Look at the uvula behind. I'll show the cursor. Can you see this uvula? So this is the same patient. You can see that the uvula is looking like a hockey stick. It is not like a hockey stick normally. Now here it is looking like a hockey stick. Now this is a picture which one of my earlier third year student, when I took the class, and she was posted in the clinics, and after an OSMF class she happened to see such a patient with reduced mouth opening and a hockey stick uvula. She immediately took a picture and sent it to me. So this is how one learns pathology. All right, when you start working in the clinics, as a part of it, this patient must have come for a different reason, but she just found that the patient has got reduced mouth opening and the uvula is showing some kind of changes. That was discussed in the class that particular day, and after a couple of weeks when she found the patient, and she just came back to me with these pictures. So this is how you will learn to read the patient's situation. This is the textbook picture of OSMF, where you can again see the uvula. So you can see that the previous picture is so nice and so descriptive than the textbook picture. All right, so many a times you will be able to see patients in person, especially OSMF patient. It is the disease of the Indian subcontinent. All right, so this is the histopathological picture where you can actually see. Now you can see three parts in this picture that I've shown you. This is taken from Causon Atlas, and it's very important to know. This is the epithelium, and you can see that the retar ridges, which would have been long earlier, are now becoming very flat. So there is flattening of the retar ridges, maybe a little atrophy of the oral mucosa. And these blue colored cells, which you can see down, is your inflammatory cells. And the entire area is highly collagenized or hyalinized. All right. But in a normal stain made up of hematoxylin and eosin, you will be unable to recognize this, different collagen fiber bundles, because the entire area takes up a pink stain, which is why it looks like a hyalinization. But at the same time, if you look at this picture, this is basically a special stain for collagen. So you can see that the fiber bundles are, have only taken up this stain, and it's become very darkly stained. So when you compare both these pictures, we know that it's the same patient, but in a H&E stain, your hematoxylin and eosin stain, it is a very non-specific staining. You only find hyalinization. But if at the same time, if you use a special stain, you can see that there is a lot of fibrosis or fiber bundles in the connective tissue. And epithelium is just atrophic. There is no change in the epithelium per se. But in a long run, the epithelium will become atrophic and become ulcerated. And then when the patient uses tobacco, the tobacco will have a larger chance to leach into the underlying connective tissue and form a lot of, problems from, further damage of tobacco use. All right. So that is about histopathology. Special investigations can be done. That is using Van Giesen stain. That's a special staining I told you. Van Giesen's Massen's trichome and Picrocereus dead. We've all made diagrams of Van Giesen and Massen's trichome before. Picrocereus red is what it's a new edition. It's a very old stain, but you've never heard about it before. Then you also have IHC markers like heat shock protein, cystatin C, survivin, etc. So these can also be used for investigating your OSMF. Having said that, OSMF does not need all these things to be investigated, because it's very easy to figure out what the problem in OSMF is clinically itself. All right. So in the blood, you can sometimes find iron, vitamin B12 and folate levels which are reduced. So you will give nutrition supplementation to the patient, and increased ESR, anemia, eosinophilia and gamma globulins will be there. So treatment is important from the oral medicine point of view. You have to restrict the habits with corticosteroid application. Hyaluronidase lesional injections. Why do you give hyaluronidase injections? Is because this will break down the collagen fiber bundles which have actually formed inside the patient's buccal mucosa, as a result of which you can slowly tell the patient to do some exercise, which is what is called as physiotherapy. Matlab, you will tell the patient that after the intralesional hyaluronidase injection, you will tell the patient to slowly do a lot of mouth exercises, like opening the mouth slowly. He'll keep trying to open the mouth slowly. Now what happens is the collagen fiber bundles will start getting broken down by this hyaluronidase, which is an enzyme, and slowly the patient will improve his mouth opening. But first and foremost is he has to stop the habit. All right. So that is why oral submucous fibrosis is extremely important for a clinician, for a academician, for a student, from the exam point of view. So it's a very important disease to know, and you cannot uh, ignore these patients just because they don't have any complaint of pain. All right. Uh, so that's about it. Thank you so much.